I'd like to welcome everybody to today's presentation on preventing and treating addictions in post-acute and long-term care. I'm your host, Dr. Dawn-Elise Snipes. In today's presentation, we're going to review the setting characteristics, post-acute care, long-term care. What are we really talking about? Discuss the prevalence of alcohol and drug addiction issues in those settings, and identify triggers and challenges or vulnerabilities faced by people with drug addictions in those settings and strategies to assist them. The settings, post-acute care is where people are discharged right after they get out of the hospital because they can't go home yet. They're not able to manage their condition at home, but they don't need a hospital level of care. And this can last, in most cases, for up to 100 days post-hospitalization. And then they're either transferred to long-term care or transferred home. In post-acute care, the goal is for them to return home. Long-term care is characterized by independent living facilities where people choose to go because they want a little bit of extra support. Assisted living facilities in which people, again, generally choose to go, but in assisted living facilities, they need assistance with 2 or more activities of daily living. This can include medication administration, but doesn't necessarily include that. Memory care, depending on your state, memory care may either be part of a nursing home or part of an assisted living facility. But this, as it sounds, is a place where people are experiencing later stages of dementia and Alzheimer's disease. And then nursing homes are high-level nursing care facilities where people do have round-the-clock nursing staff and require that kind of care for some reason. Addiction prevalence in the general population, and you'll understand why we're talking about that in a minute. 5.8% of people abuse alcohol. 2.1 have an addiction to benzodiazepines or your anti-anxiety medications. And 1%, I think that number is way too low, but that's what the statistics said, 1% misuse or are addicted to opioids. So when you add that up, I should have done it for myself earlier, that's about 22 million people who have addictions in the United States. In 2018, approximately 1.3 million people were admitted to hospitals due to alcohol-related conditions, accounting for 7.4% of all hospital admissions. Now, to get to post-acute or long-term care, most of the time, people with addictions are going to start through the hospital route. They're going to have something happen that lands them in the hospital that needs to be monitored in a higher level of care than home care. So they're transferred into post-acute or long-term care. In Canada, between 2019 and 2020, 4.2 of opioid-related hospitalizations had a co-diagnosis of anoxic brain injury. What that means is 4.2 of the percent of the people who were admitted for opioid-related causes had brain injury because of a lack of oxygen. That's a problem. Obviously that's potentially going to be a permanent brain injury. In 2019, 3% of all U.S. hospital admissions were directly attributable to opioid-related conditions, including overdoses, infections like endocarditis or inflammation of the heart, and anoxic brain injuries. So let's look at the statistics. There's about 36,200,000 hospitalizations in the U.S. each year. 21.1% of them, or about 7.5 million, are referred to skilled nursing facilities. So you've got, let's just round the numbers for simplicity, 7.5 million people are referred to post-acute or long-term care. Of that 7.5 million, 85% of them, or 6.5 million basically, met criteria for opioid use disorder. So that tells you that there are a lot of people in these settings that are struggling. They're either in recovery from or currently dealing with an addiction. 53.33% met criteria for cocaine use disorder, and 27.5% met criteria for alcohol use disorder. And I know when you add all those up, you're like, wait, that's way more than 100. That's true, because we have a lot of people are polysubstance abusers. It wouldn't be surprising to see somebody who had opioid use, cocaine use, and alcohol use disorder altogether. But my point in driving that home is a lot of times we think, oh, the people here, they've got diabetes, they had a heart attack, there's no drug addiction. Oh, yes, there is. And we need to be aware of that because it's going to cause some potential challenges. It's important when we meet patients who are admitted to post-acute or long-term care that we screen for co-occurring issues. If they're admitted to the post-acute care or long-term care facility because of infections, complications from diabetes, myocarditis, kidney failure, traumatic brain injury, acquired brain injury, stroke, depression, or even cancer, there's a high correlation of those issues with addiction. So we need to kind of start asking questions about any history of substance use. And we don't need to do it in a punitive way. In general, at least in all the facilities that I've been in, a substance abuse screening history has always been part of the general intake. Just so we know, I'm not necessarily going to diagnose somebody with a substance use disorder, but if they used cocaine heavily for the past 3 years, kind of good to know. Even for people with no known drug addiction, they get admitted for something other than a drug-related problem. If they are self-administering opioids or benzodiazepines, anti-anxiety medications, it can become an issue. Yes, in most of these facilities, patients are able to be given permission to self-administer medications. And especially in post-acute care, the goal is to help them go home. So generally, if the patient is able to self-administer medications, they are given that privilege, even if we're talking about something like opioids or benzos. If the person is struggling with depression or anxiety, they may start self-administering their medication a little more than they're supposed to because they're self-medicating. Not saying they will, but it is a risk, especially in the facility environment, in the post-acute care, long-term care, where there may be issues where they're feeling isolated, where they don't have anybody to talk to, they don't feel like they've got social support. They may start self-medicating. There's also the issue, and I know I have this issue with my meds that I take every day. It's like, okay, did I take my meds today or didn't I? And I don't have dementia by any means, but it's easy to forget if you've got your mind going in 6 different directions. People who are in post-acute care are often recovering from illnesses and injuries. They're not sleeping so well. They may be on other medications or what have you that are giving them some brain fog. So they may forget they took the medication and take it again because they're like, oh, my hip really hurts. I must have forgotten to take my opioids. Let me take them now. And then you can start seeing a person taking their meds instead of taking them every 4 or 6 hours like they're supposed to, taking them occasionally every 2 hours. And of course, that's not okay. So we need to monitor that with pill counting. Pills, if somebody is self-administering their medication and they have control over the lockbox in which their medication is stored, then staff needs to be regularly counting those pills, not necessarily daily, but at least weekly, to make sure that the right number of pills are there. And When I worked in residential substance abuse treatment, we were a level 3.1. So the clients still self-administered their medication, but all their medication was stored in the nurse's office. They took it under observation by the nurse, and it was signed off in the medication log. So there was a lot of monitoring there. In some facilities, especially assisted living facilities and independent living facilities, the patients may have their medications stored in a lockbox in their own room, which again is a reason that we need to make sure that we're keeping an eye on it. Medications that are self-administered are also subject to diversion to other people in the facility with addictions. If the person is in a shared room, for example, and they've got a lockbox that has their medication in it, and they go out to a group and they leave the keys to their lockbox there, and the other person who's in their room knows where the keys are kept, they can go in and get the medication. Now, old-fashioned keys and lockboxes, that's just a bad setup anyway, in that sort of environment. But if people have access to lockboxes, it can be a problem. People who are in these facilities sometimes also have some cognitive deficits and may be more easily manipulated to share their medications. It's like, hey, I'm in a lot of pain and my doc hasn't refilled my prescription yet. Can I have a couple of yours? And, just wanting to be nice. The person who has the opioids or the benzos may be convinced to share, don't tell anybody, but they do it. Something that's a little bit more overt is cheeking. If the facility monitors the substance dispensing, so just like in my facility, the patients would come to the nurse's station and take their medication under observation, they can get really good at cheeking that medication. They either put it up between their teeth and their cheek, which is why it's called cheeking, or under their tongue until they get out of the office. Then they spit it out and they can give it to somebody else. And yeah, it sounds gross, but it happens. It's just the way it is. And if medications that are more likely to be abused or diverted are being dispensed in the facility, it's always a good idea to have, when the person takes their medication, monitor it and make sure they took it, look in their mouth. And that can be a point of consternation in a lot of facilities because they feel like that is too invasive, especially if they are not drug addicts, if they haven't been diagnosed with that. A significant proportion of long-term care residents have opioid prescriptions, according to a study in 2022. Assisted living facilities in most states do not prohibit the recreational use of alcohol by residents and may allow it to be kept in their rooms. The Older Americans Act of 1965 was put in place, and it's been modified and enhanced and everything, periodically up until today. But it is one of the pieces of legislation that ensures that people who are in assisted living facilities and nursing facilities have the rights that they would have outside. It protects their rights to self-control, self-determination. Therefore, in some cases, ALFs have determined that they don't have the right to prohibit someone from drinking alcohol. They're legal. If they could do it, if they weren't in the ALF, they were living in an apartment somewhere, if they could do it there, they should be able to do it in the ALF. Now, all assisted living facilities have different policies, and alcohol consumption is not regulated in those facilities by any sort of governmental agencies or powers that be. So it is a facility-to-facility issue. However, if you've got people who are struggling with depression or anger or grief at being in the facility, and they have access to alcohol, they may start developing alcohol-related issues. Likewise, the alcohol's probably not being stored in a locked area. So if you have someone who is in the facility who has an alcohol addiction or has had an alcohol addiction, once they know where that alcohol is, there's going to be a strong pull to try to access it. It's like, oh, it's right there. And that can cause a lot of triggers and cravings in that person. As a therapist, I'm going to work with that person to help them figure out how to deal with those cravings. When they were on the outside, when they weren't in that facility, the local 7-Eleven had alcohol. How did they stop themselves from going to the local 7-Eleven to get alcohol? Same sort of thing. In the assisted living facility, alcohol's out there. How can they stop themselves from taking advantage of that? It's also important to remember, and I know many people are like, you've got to be kidding. No, I'm not kidding at all. Hand sanitizer can be and is regularly ingested by people who have alcohol use disorders who cannot access regular alcohol. Most hand sanitizers contain 60 to 95% ethanol or isopropyl alcohol to effectively kill the bugs, which is a higher alcohol concentration than most alcoholic beverages. And we saw this increase dramatically, no surprise, during the pandemic, because all of a sudden, all these hand sanitizer stations started popping up everywhere. And when I was running the residential facility in Florida before the pandemic, we actually had to remove all of our hand sanitizer stuff because we had patients drinking it. I'm not sure how they pivoted during the pandemic and to make hand sanitizer available and safe. But based on my research for this presentation, they haven't created a safe one yet. And we do want to be aware of that. If we've got a patient who has or has had a problem with alcohol, we need to recognize that those hand sanitizer things all over the place are it's like having a shot glass sitting on the bar, and it can be a really strong trigger for them. So let's talk about vulnerabilities. We're going to talk about vulnerabilities and triggers, and sometimes they overlap, but vulnerabilities are things that make a person more prone to be triggered. For example, if I don't get enough sleep, I tend to be a little bit more irritable, and things that normally wouldn't trigger me or bother me get to me. Poor hand washing is a vulnerability for germs to be able to trigger an illness. A lack of perceived support is a vulnerability. If I'm feeling isolated and unsupported, then when challenges come up, I may be more vulnerable to have my anxiety triggered because I feel like I'm already overwhelmed. Vulnerabilities that we have to address in long-term and post-acute care: sleep disruption. Sleep disruption increases intrusive thoughts, it increases irritability, it increases activation of the sympathetic nervous system or the fight or flight part. We need to address this because when people are in fight or flight, when they have brain fog, when they have intrusive thoughts, it's harder to manage cravings. It's harder to manage emotions. So addressing sleep disruption, it's huge. And I have several videos on the channel that talk about sleep hygiene and those sorts of things. Remember, if you've got somebody who is being awakened throughout the night, maybe they're in a shared room and their roommate has sleep apnea, they're getting awakened, or the nurses are coming in and out all hours of the night, which doesn't generally happen in post-acute care. Generally, that's more of a hospital thing, but who knows? Or maybe their roommate gets up and goes to the bathroom 3 times a night and they wake up. So we do want to figure out how to help them address sleep disruption. Circadian rhythm disruption, and I know I harp on the difference. Circadian rhythms regulate all of our hormones in our body. It regulates most of the systems in our body. Circadian rhythms are set by light levels, but they're also set by temperature. Cooler temperatures trigger the rest period, and warmer temperatures trigger the awake period. And social activity. So getting up and going to breakfast is really important. Going to lunch at the same time each day, really important. That can help set those circadian rhythms. So then when it's nighttime, the body goes, oh, hey, we just went to the cafeteria and had dinner. Now it's time to start winding down. Helping people set and maintain their circadian rhythms in these environments is really important to managing distress. As distress goes up, the risk of relapse and substance abuse goes up. So this is huge for relapse prevention. Another one you may see is menopause or andropause. A lot of people, once they've gone to a nursing home, we think of as being older. But because there has been such an increase in people with brain injuries or infections or other things caused by drug abuse, the mean age of people in post-acute care and long-term care has gone way down. It is not uncommon to see people, especially in post-acute care, who are in their 30s, 40s, 50s, and may be going through menopause or andropause. Those hormonal changes can contribute to sleep disruption, irritability, distress, which are all, guess what? Vulnerabilities for being triggered and engaging in addictive behavior. Pain. Now, this one is both a vulnerability and a trigger, but pain can be caused by a lack of movement. If somebody is sitting in bed all day long, that can cause pain. If somebody's in bed all day long and they can't move themselves and they're not getting turned every 2 hours as required by law, then they may develop bed sores, and those are excruciating. Injury recovery. We all, when we've had an injury, if you broke something or you've had an amputation or whatever caused you to be in post-acute care, even after surgery, if you have open heart surgery, it hurts. And that can make people more vulnerable. It can make it harder for them to sleep. It can make it harder for them to deal with life on life's terms because they're in pain. And pain triggers that sympathetic stress response. Helping people develop tools to manage their pain is really important. And chronic conditions, whether it is osteoarthritis or lupus or some other chronic condition that causes pain. Working with people on using pain scales, working with people to help them focus on ergonomics. What could they do ergonomically to prevent as much pain? Maybe it means changing their bed or getting a different pillow or getting up and moving, sitting in a chair if they can. Guided imagery for pain and acceptance and commitment therapy for pain can also be really helpful because sometimes pain just is. You can't get rid of it. And acceptance and commitment therapy says, okay, I can choose to move toward my rich and meaningful life and be experiencing some pain. Compassion can also be helpful, compassion-focused therapy for people who are really hard on themselves because they can't do everything they want to do because of their pain. Well, if they start getting angry with themselves, again, they're just using a lot of unnecessary energy. Knowing that pain can make people more vulnerable to distress, knowing that pain can actually trigger the desire to use to numb that pain, it's a big one we need to address. If they have a history of addiction, that makes them more vulnerable. They've already learned at some point in their life that if they use this substance or engage in this behavior, it numbs the pain. Now, it may have all kinds of negative consequences, but they're thinking about right now. What can give me relief right now? So people are at a much greater risk of relapse if they have a history of addiction already. And then post-acute detoxification, post-acute withdrawal symptoms. Many of these patients who are referred because of substance-related injuries haven't been detoxed for very long. They detoxed in the hospital, so the acute phase of detox is past. They are theoretically, quote, medically stable, but their brain and their nervous system is still all out of whack. Their symptoms, their fatigue, their irritability, their sleep changes, that's all still a big issue. And when they're experiencing post-acute withdrawal in this period, what I call post-acute detox, it can be very stressful and very frustrating and exhausting, which can make people, again, more vulnerable. Interpersonal vulnerabilities. Well, when you're sitting in a hospital all by yourself and the nurses are busy, they can't just chat with you. And a lot of times people are sort of siloed. Even if you're in a long-term care facility, a lot of times people stay to their own rooms and they don't go out, they don't socialize, and they feel like they've got a lack of support. When things bother them, they don't have a sounding board to help them try to figure it out. So it's important to understand that a perceived lack of support is a vulnerability for relapse. It's a vulnerability for being triggered because they don't have anybody they can go to and say, hey, I really feel like using, help talk me off the ledge. Low self-esteem and low self-efficacy. I feel bad about myself and I don't feel capable of managing what's going on with me are also both vulnerabilities. When people feel like they're not capable of staying sober, when they feel like they're not capable of recovering, or they don't feel like they deserve it, then they tend to be more likely to want to numb things up. When things happen, the person with low self-efficacy says, well, that's more than I can deal with, so I deserve a drink. Poor communication skills. When people have difficulty communicating their thoughts, their wants, their needs to themselves as well as to others, they have difficulty getting those thoughts, wants, and needs validated and met. And that can make somebody feel very isolated and very helpless because they're like, I can't do this on my own, but I don't know how to tell you what I need. So they're more vulnerable when triggers come along for that addiction because they don't have a way to communicate that's really triggering for me. Fears of abandonment may be a vulnerability because people who are afraid of abandonment often are reticent to tell someone no. They are reticent to stick up for themselves or state their thoughts, wants, and needs. They don't want to be a bother because they don't want you to abandon them, which means they're suffering in silence. And that suffering in silence, again, puts them in a place where they are already stressed out. They're already irritable or anxious. And it's not hard at that point for them to be triggered, or said a different way, it's harder for them to deal with life on life's terms. And finally, unresolved trauma causing anxiety and hypervigilance and generally not feeling safe. That's going to impair their sleep. That is going to contribute to intrusive thoughts and ruminations that they just want to shut down. And they can use a lot of energy trying to figure out what to do to feel safe. Well, if they're using all that energy to do that, then it's hard to deal with anything else that comes along. Whatever else comes along is the straw that broke the camel's back. Helping people figure out in this environment, what can you do to feel safe and empowered? What can you do to identify your needs, and how can I help you better communicate them? Emotional vulnerabilities. People who have addictions often have low, what we call emotional intelligence, or a low emotional quotient. It doesn't mean they aren't smart. It means they have difficulty identifying emotions in themselves and maybe others, understanding the function of those emotions, understanding where those emotions are coming from and how to deal with them. And we see this in a lot of people who have addictions. That's one of the skills they didn't learn. And in recovery, one of the things we hear in early recovery is the best thing about recovery is I can feel feelings. And the worst thing about recovery is I can feel feelings. Because that's a whole new experience for a lot of people who've been numbing their emotions for years. Helping them develop emotional intelligence, excellent intervention to help them develop a sense of awareness of what's going on with them. Poor coping and distress tolerance skills. Substances were often used to numb the pain, to escape, and helping them develop coping and distress tolerance skills is important. If they're in recovery, they probably developed some coping and distress tolerance skills already. But this is a whole new ballgame and a whole new set of stressors that we may need to help them deal with. If they're in post-acute or long-term care, I feel it's safe to say most of the time there is some level of anxiety about whether they're going to recover and or grief about abilities or whatever they've lost as a result of whatever landed them in post-acute or long-term care. If the person has a history of psychiatric disorders, mood disorders, bipolar disorder, schizophrenia, stress is known to trigger an episode of mood disorders or psychiatric disorders that have been in remission. Helping them be aware of their relapse warning signs for their psychiatric disorders. What are the first signs when you're getting ready to have a depressive episode, when you're starting to feel anxious, when you're starting to move into a panic episode? What are some of those warning signs? Helping them develop that. Helping them develop an awareness of strategies they can use to try to reduce and prevent the flare-up, if you will, of the psychiatric disorders. When you're not struggling with depression or anxiety or breakthrough symptoms of your schizophrenia, what's different? What are you doing differently that helps reduce your stress? And how can we do that now? Cognitively, they may perceive themselves as helpless. Helping them restructure their thoughts is pretty straightforward. If I perceive myself as helpless, then when a trigger happens, I'm more likely to go, well, I can't deal with it. So, I'm going to suffer the consequences. A lack of motivation to do the next right thing is also a vulnerability. Some people, when they're admitted to post-acute or long-term care, sort of give up. They're just like, whatever, screw it. And that can lead them to be more vulnerable to engaging in addictive behaviors. Objectively, in the moment, most addictive behaviors are pleasurable, and they may be seeking that immediate relief. Even though the long-term consequences are devastating, they may be seeking that immediate relief because they don't have the motivation to move forward. Executive functioning deficits, especially memory and problem-solving issues, are also vulnerabilities. Memory for what medication I'm supposed to take when, if I took my medication, or problem solving. When I start feeling stressed, this is what I need to do. And all of that stuff is prefrontal cortex stuff. And depending on the part of the brain that was impacted, there may be difficulty for the person managing their executive functioning. If they have ADHD, executive functioning deficits are a big issue. If they have addictions, we often see a lot of people with addictions have some level of executive functioning deficits. Not that they can't be recouped or learned or whatever, developed. But if the person knows that they tend to be more impulsive, that they tend to have difficulty problem solving, especially when they're stressed, we need to help them develop those distress tolerance skills and a plan for, okay, once I get grounded, what's my plan for how to deal with triggers when they happen? And in the environment that they're in, it's a vulnerability. Yeah, you can't avoid it. It's the safest place for them to be in theory, but they're being constantly exposed to triggers for substance use, triggers that may trigger their grief, their anxiety, their depression. A lot of long-term care facilities are not super happy places, and I wish that wasn't the case, but it is. And a lack of adequate supervision. If Jim Bob is struggling with an addictive disorder and knows that the nursing staff that's on between 11 p.m. and 7 a.m. typically sleeps and they're not watching what's going on, then guess what? He's going to probably try to take advantage of getting those meds. If there's somebody handing out medications, they put them in the little cups and they set them on your tray and they're not paying attention. Or sometimes they have the person with the addiction has the motivation to cause a distraction and the nurse gets distracted, then they can swipe those meds and nobody's the wiser. So that can be a problem, and that's an organizational issue that needs to be addressed. Triggers. Now, remember, vulnerabilities make it more difficult for people to deal with life on life's terms, which makes them more vulnerable to these triggers. When they happen, each of these triggers can feel like the straw that broke the camel's back. Protracted withdrawal and cravings, especially for lipophilic drugs. Lipophilic drugs are drugs that are stored in fat tissue. And believe it or not, opioids, benzodiazepines, cocaine, and cannabis are all stored in fat tissue. And a lot of people know that cannabis is stored in fat tissue, but many people don't realize these other drugs are. What does that mean? That means if they're in post-acute care, long-term care, and they start losing weight, which a lot of people do because they're not eating the same burgers and fries that they usually do, as they lose weight and that fat is released, some of the drugs are also released in the system. So they may have a resurgence of cravings and sort of symptoms, not to the level of intoxication, but they may have a resurgence of symptoms. And those drugs may show up, depending on the sensitivity of the trip test, they may show up, especially on a on-site urine screen. Doesn't mean they took them again. It may mean that they're being released from the fat tissues and they're at a detectable level. What can we do about that? We can educate patients about protracted withdrawal. We can help them monitor their signs and symptoms of protracted withdrawal so they can communicate them. I'm having really strong cravings today, or whatever symptom they happen to be having, so staff can be supportive. Some people who were on medication-assisted therapy prior to coming in are unable to get their medication-assisted therapy in the facility. And I'm not sure how that's even legal, but apparently it is. And of course, that's a trigger. If you're used to getting your buprenorphine or your Suboxone or your methadone or whatever every single day, and you can't get it, then you're going into a hard withdrawal like that. And that's definitely going to cause irritability and consternation. If they're able to get it, but the medication-assisted therapy clinic doesn't deliver it on time or misses a day or something, then you're potentially going to have a lot of anger and irritability and distress. So there needs to be a plan. If the person's on medication-assisted therapy, how are they going to maintain that? Or if they're not able to maintain that, how is the medical staff at that facility going to manage those symptoms? I mentioned pain was both a vulnerability as well as a trigger. And so we've got it here again. If I'm already stressed out for some reason, whatever reason, and then I get a headache, that is going to feel a lot more overwhelming than if I wasn't stressed out and I got the headache. For people who are recovering from addictions, especially addictions to opioids, benzodiazepines, and muscle relaxers, pain can be a significant trigger for wanting to use again. And again, ergonomics, guided imagery, working with the physical therapist, referring them back to their physician for other strategies and prescriptions, hot and cold therapy, massage. There are a lot of things that can be prescribed. TENS units, transcutaneous electronic nerve stimulation. You can get them off Amazon. And they're basically little like EKG pads that you put on your skin, and it bombards the nerve endings, which confuses them. So they quit sending the pain signals. Very oversimplified. But they've also found that it increases the level of opioid activity or endorphin activity in that area for up to 3 hours after the TENS unit treatment. So that can be helpful for some people for certain types of pain. Medication availability, and I have that in quotes because if a person with an addiction is in one of these facilities, they know there's medical staff there. They know that there is the possibility of getting it. And it's just a matter of how to manipulate the doctors to write a script for them, or how to manipulate the other patients to get them to share their prescriptions. And yes, it happens. Is it as malicious as it sounds? I really don't believe so. I think it is a learned behavior that flares its ugly head when the person is feeling completely overwhelmed. But we do need to be aware of that. If you've got a lot of ALFs, and especially, and some post-acute care facilities have medical staff that are coming in on contract. So they may not be communicating with each other as much as they should. It's really important that the doctors are communicating about what's going on with the patient, what has been prescribed, and if the patient is exhibiting med-seeking behaviors. When it comes to other patients, facilities need to have a very clear policy about not sharing their medications. Doesn't mean it won't happen, and then seeing or knowing medications are right there. One of the most common problems for diversion in post-acute care is that med cart that goes around. Like I said, the meds are in the little jars and just ready to be handed out to people. But sometimes the staff will get sloppy and leave the med cart unattended and unlocked. And that is a huge risk factor for diversion, because generally it doesn't just happen once. And generally the person who does it regularly. So if I tend to be kind of sloppy with my med cart, then people in the facility with addictions are going to learn that. And they're going to plan on how to divert the medications. But just knowing the meds are there can be a huge trigger. It can make the person feel like they're kind of, sitting on the edge of their chair because it's so close. Think about, not in one of those facilities. Think about someone with an alcohol abuse problem going into a bar, and they don't have to order, true, but the alcohol's so close. It's right there. It's so hard not to take advantage of it. And that can cause a lot of ruminations and intrusive thoughts that we need to help people figure out, how can I manage that? And then rehab setbacks can also be huge. If I'm in treatment, and I had a friend who broke both of his legs doing, that dirt bike stuff where they jump real high in the air, broke both of his legs, both bones in the lower legs in both legs, and he had to have them pinned back together. And he was in post-acute care for about 100 days, and then he got discharged. And he very quickly had to have some more surgeries and go back into post-acute care because one of his legs didn't want to heal. It became necrotic. But that was excruciatingly frustrating for both he and his wife. Not only physically painful, but it kept him from moving on with his life, and it felt overwhelming. Now, he didn't have an addiction, but I'm just kind of sharing with you the types of rehab setbacks that somebody may have where they think, okay, I've got this covered. In 6 months, I'm going to be finished with physical therapy, and I'm going to be able to resume life as I knew it. And then that doesn't happen. And that can feel overwhelming. It can feel like a punch in the gut. And obviously, it can trigger a lot of grief because what they expected to have happen was just yanked away from them, which can be a trigger for desire to use. Interpersonally, again, a lack of support can be a trigger. If my kids aren't coming to visit me, then I am going to potentially be angry, and I may start feeling a lot of self-pity and decide that I want to numb that up. Self-hatred, well, we don't want to feel that. People want to numb that up. So if I start feeling self-hatred, then I'm probably going to be looking for a way to make that stop. Maybe I don't want to make myself stop, but I want to make that pain stop. A loss of friends. In post-acute care, remember, they're only there for up to 100 days, so people get discharged. You may start getting to know a couple people who admitted the same time you did, and then they get discharged and you're still stuck there. And that can be trigger grief and trigger the desire to use. It can trigger frustration. So this is one of those acute stressors that pops up that can be problematic. Sometimes, especially in long-term care, the person or people that you are getting close to either die or their dementia progresses to the point where they can't remember you or who they are and may even have to be transferred to memory care. So it's a loss. Even if they didn't physically die, their brain may have kind of checked out. And grieving the loss of the friendship with that person who doesn't recognize who you are, especially for people who are in long-term care because of dementia, that can trigger a lot of anticipatory anxiety and anticipatory grief, which again can make them want to use. If somebody is easily manipulated by others, that can be a trigger that we want to pay attention to. If they want to be accepted, if they want to be liked, and someone who's unscrupulous decides to try to use them to get their prescriptions, get their medication, we need to address that. We need to address both the person with the addiction who may be trying to manipulate others. We also need to address the other people in the facility who may be easily manipulated and help them learn how to set boundaries. Emotionally, distress, anger, guilt, resentment, anxiety, depression, grief, the whole gamut. All of these things we don't like to feel. And that's why we talk about developing distress tolerance skills, but it's still not something that we enjoy sitting with. And some people may start feeling overwhelmed by their emotions and feel like they can't tolerate it anymore. Those are things we need to work on with them to help them develop distress tolerance skills and distress tolerance thoughts, and a sense of safety and empowerment, a sense that there is hope, that they can do something to move forward from this particular situation. Cognitively, I mentioned earlier, poor sleep and disrupted circadian rhythms are going to contribute to intrusive thoughts and ruminations. Being in this place, having triggers, especially visual triggers everywhere around you, can trigger thoughts of past use. It can trigger memories of past use and trigger a lot of ruminations in people. helping them figure out, how can I deal with those? What can I do to create a safe space? As facility managers, managers need to figure out, what can we do to reduce triggering people who have a history of addictions, people who've used needles before for administering drugs are going to potentially be triggered even by insulin shots people are giving themselves. They're going to be triggered by needles. And making sure that for any patients that need to have some sort of needle or IV or something, that is done in the nurse's station. So the common areas are free of as many visual triggers as possible that may make somebody think about using. People can also get triggered by thoughts or awareness of the illness or injury's impact on their rich and meaningful life. I've got this now. So, and I'll talk about my friend again who broke both of his legs. His career doing sport biking or motocross or whatever you call it, it was over. And that was a big thing in his life. And I can't imagine the devastation and that he had to go through. But yeah, he thought about that. That changed his image sort of himself. Environmentally, long-term care and post-acute care facilities are filled with triggers. Med carts and med boxes, the medication's right there. It's so hard to resist. But you've got to. Other patients taking medications, whether it's oral medications, IV bags, and needles, those are very triggering for people. Even the ports, people who have cancer, who have to have medication regularly injected, may have a port inserted. And those ports can also be triggering for people with opioid use disorders or some other disorder where they used a needle. Even nursing uniforms. Nursing uniforms says medical says drugs. That's what I want to think about. Those can be triggering for some people. And as I mentioned, hand sanitizer, especially for patients who have a history of alcohol addiction, hand sanitizer and to a certain extent mouthwash, both can be triggers, and because they know in their brain, hey, if I use this, I can get high. As a side note, some people will misuse antipsychotics to get high. And this is something that I learned about from my patients. And I'm not going to explain how to do it because obviously that's not productive. But recognize that misuse, antipsychotics may be diverted and misused. The Food and Drug Administration requires manufacturers to label antipsychotics with the strongest black box warning about the risks they pose to people with dementia and to the elderly. The FDA has never approved antipsychotic drugs as safe and effective treatment for dementia symptoms like agitation and sundowning. But guess what gets used in a lot of these facilities to address agitation and sundowning? What gets used in a lot of treatment facilities because they don't realize the person has early stages of dementia. Antipsychotics. More than 30% of residents in long-term care and post-acute care facilities are given antipsychotics, which contribute to falls, disorientation, excessive sleepiness, and consequent cognitive decline. The more they disengage, the less they're up thinking, learning, engaging, the faster their cognition is going to decline. There is a significant prevalence of people in post-acute and long-term care with addiction or a history of addiction, while some people even develop addictions while in post-acute and long-term care. Clinicians must screen for addiction and assist in both the prevention, so they don't develop it while they're there, and treatment and relapse prevention strategies. For people who have active addiction, we need to help them address that because it's going to slow their recovery. For people who have their addiction in remission, however you want to say it, they're in recovery, we need to help them with relapse prevention strategies because they're being exposed to a lot of potential triggers and stressors that make them more vulnerable to those triggers. Post-acute and long-term care facilities must regularly survey their programs for medication misuse, count those pills, diversion, make sure that the medication that's supposed to be on the cart is on the cart, and including misuse of atypical antipsychotics. We went through a lot, but hopefully if you work in one of these facilities, you recognize that there are a lot of people who may not have been admitted there for an addiction-related issue, but they've got it going on, or had one at one point and are at risk of relapse. So we can prevent and intervene as quickly as possible. Do you have any questions? To get your CEUs, go to allceus.com and log into your account, take the quiz, and once you pass with at least an 80%, you will be able to print your certificate. I'm glad it was helpful, Stuart. You are quite welcome, Smarty. You're welcome, Veronica. Everybody have a wonderful day. Well, I'm glad the videos are helpful, Christopher. If there are particular topics you would like a shorter video on, please feel free to email me at support@allceus.com, and I will put that on the list of shorter videos to make.